Hello, everyone, and welcome to our question lab. This evening's topic is musculoskeletal. My name is Sean, and joining us today and leading our session on musculoskeletal today is Paras. And Paras, do you want to introduce yourself?
Hi, thank you, Sean. Hey guys, my name is Paras. I'm a dermatology resident here in Dallas, Texas at UT Southwestern. Calling from the nice sunny state of Texas today. I originally graduated from St. Louis with my pharmacy degree, then went back home to Michigan and do my medical degree. And now I've been working with USMLE-Rx as well as an RX coach, working with students one-on-one to help them prepare for the USMLE Step 1 and Step 2 CK as well.
My name is Sean. I've been with Scholar RX and for a little over 2 years, primarily working on RX Coach, which is our tutoring and coaching initiative. So with that, I know I mentioned RX Coach earlier. RX Coach is our tutoring and coaching program, which we will talk more about later this evening. But for now, what you should know is that the methodology we will be using this evening is going to be the same methodology which we employ in our RX coaching program. So with that, let's go ahead and get into our first question of the evening. As you can see, the answer choices are covered up, and that is by design. We do that because we do not want you to be guided. We don't want your thought process to be guided or dictated by the answer choices. We also don't want you to see an answer choice that you are unfamiliar with, which may cause you to panic or second guess yourself as you're trying to read and answer that question on test day. So I've gone ahead and removed those answer choices for you. After that, we will begin by reading the lead-in. The lead-in is the last sentence or the question itself. And the lead-in with this vignette is, which of the following is most likely obtained on patient history? And we read the lead-in first because that allows you to know what the test writer is asking so that when you start reading the vignette, you can pick up on all of those relevant clues and prevent yourself from having to reread that question and waste valuable time on test day. After we read the lead-in, we'd like to ask our students how many steps they believe this question will require. An example of a one-step question could be where they ask you for the diagnosis. An example of a two-step question could be where they ask you what is the treatment for a diagnosis. And an example of a three-step question could be where you're asked what is the mechanism of action for a treatment for a diagnosis. So with those examples in mind, please let us know in the question box how many steps you believe this question will require, and then we'll read the vignette. I'll give all of you a few moments here to respond. All right, I see the responses coming in, so let's go ahead and read that vignette. A 27-year-old man presents to the clinic because of a 5-day history of pain and swelling in his upper right arm. His CBC shows a slight leukocytosis, but is otherwise normal. MRI of the area reveals diffuse soft tissue and bone inflammation. Bone biopsy is performed, and you can see the image there. Blood cultures grow a gram-negative, oxidase-positive rod. I'll give all of you a few seconds to take a look at that image. And then the lead-in. Which of the following is most likely obtained on patient history? So I want all of you to start thinking about the important clues in this vignette as I hand it off to Paras.
Thank you, Sean. So we'll go ahead and show you what we think are the important clues in the vignette and the lead-in. So as you guys usually know, demographics is always important. So what we're going to show you is a 27-year-old man. That's going to give us clues as to what the pathology may be. Furthermore, what is this patient coming in with? Not just the signs and symptoms, but the duration as well. So a 5-day history of pain and swelling in the right upper arm. Okay. Furthermore, we know that there's a slight leukocytosis, and then they also did an MRI that showed soft tissue and bone inflammation. They did a bone biopsy, and we're seeing that picture. And then blood cultures also grew a specific organism. So taking a look at that picture, we'll now take a look at that lead-in. Which is most likely obtained on history? So what could we maybe hear in the HPI of this patient that may have led to this pathology? Okay, So how many steps do we think this question is? Well, one, I think, we need to figure out what's going on. So what's the diagnosis? Two, maybe what caused the diagnosis? And then three, what would maybe be a risk factor? So I think maybe a three-step question here. Let's take a look at those answer choices. And we have 5 answer choices there. And what I'm going to do is I'm going to actually start at the bottom and work my way up to the top, okay? And the reason we recommend students do this is because, a lot of times we see students who work their way from the top, and then they'll see something they like, and then they'll pick it. And then, they haven't gone through all the answer choices, and then in this way they've biased themselves. So what we like to recommend students do is work your way from the bottom to the top, just a good habit to build. This way you will not bias yourself. So let's go ahead and do that now. Answer choice E, sickle cell anemia. D, multiple sexual partners. C, miliary tuberculosis. B, IV drug use. And A, corticosteroid use. So go ahead and think about this first couple seconds. We'll go ahead and open up that poll. Go ahead and select the answer you think is the best answer, and we'll talk about it in just a few seconds.
Excellent. So I've gone ahead and opened up that poll. We'll give all of you a few seconds here to respond. I'm proud of the group because we normally don't show the answer choices while Faris is explaining the vignette. And even though we did that, none of you jumped to the answer. And it's important that you don't do that. The process is important. It's going to help you stay consistent, minimize any errors you may have, and prevent you from making those careless mistakes. So we'll give all of you a few seconds here to respond. Then we'll go over the correct and incorrect answer choices. All right, now let's take a look and see what you selected. And 51% of all of you selected IV drug use. So that was a clear favorite. Let's see what the correct answer is. And the correct answer is, in fact, IV or intravenous drug use. So great job to all of you. Way to start off the night on a strong note. So with that, let me hand it off to Faris.
Thank you, Sean. So yes, great job, guys. So this patient was presenting with a few things. So 5-day history of pain and swelling in the right upper arm. There is slight leukocytosis, and that MRI is telling us that there is some inflammation in the bone and the surrounding soft tissues. This should automatically make you concerned for osteomyelitis, okay? And then when you look at that image, what you also see is you actually kind of see almost like an abscess within the bone, and you see a lot of neutrophils and other inflammatory cells. And this is also suggestive of an infection, okay? So an infection within the bone, think osteomyelitis. There are many risk factors for osteomyelitis, okay? Osteomyelitis patients with IV drug use are more likely to present with Staph aureus osteomyelitis or Pseudomonas osteomyelitis. In this case, they told us that the blood cultures were growing a gram-negative oxidase-positive rod. So this was likely Pseudomonas, okay? Let's talk about the other answer choices if you selected those and talk about why those are incorrect. So sickle cell anemia, good thought, in case you were thinking patients with sickle cell are at risk for osteomyelitis due to salmonella, but keep in mind that is a gram-negative oxidase-negative rod, okay? Patients may also be at risk for staph osteomyelitis as well with sickle cell, but that's a gram-positive organism. Answer choice D, multiple sexual partners. That would put a patient at risk for sexually transmitted diseases like gonorrhea, syphilis, and others, but none of those organisms fit what's going on in this picture. Answer choice B, miliary tuberculosis due to Mycobacterium tuberculosis. These patients are at most risk of vertebral osteomyelitis, known as Pott's disease, okay? It is uncommon for tubercular osteomyelitis, like this bone, okay? So the humerus would not be a classic case for that, so unlikely to be C. Also, Mycobacterium does not gram stain, and we already know that there's an organism in the blood that does gram stain. And then lastly, answer choice A, corticosteroid use. This can lead to immunosuppression and also specifically osteoporosis, but doesn't predispose to this patient's condition. So the best choice after looking at all the clues in the image, would be Pseudomonas, which would be a risk factor of IV drug use. Oh, and then sorry, on this next slide as well, Sean has actually pulled up a table looking at Pseudomonas, and you can actually see that one of the things it's associated with under the O is osteomyelitis, okay? And then also people who inject drugs under the letter A for addiction, okay? So these patients who inject drugs are at risk for Pseudomonas, and Pseudomonas is also a risk factor for osteomyelitis.
Excellent. Thank you very much, Boris. And we've been having students ask us when the First Aid 2021 will be incorporated with RX 360, and the digital version will be available. As you can see with my screen, First Aid 2021 is now available digitally for those of you who have a subscription. So excellent. Great job, everybody. Let's move on now to the second question of the evening. Once again, the answer choices are covered up, and we will begin with the lead-in. Which of the following conditions has a pathophysiology similar to that responsible for this patient's rash? Which of the following conditions has a pathophysiology similar to that responsible for this patient's rash? So I'll give all of you a second here to think about how many steps this question requires, and then we'll read the vignette. All right. I see the responses coming in, so let's go ahead and read that vignette together. A 5-year-old girl presents with a 1-month history of an itchy rash. The patient's mother denies any contact with sick persons or recent travel. The patient has a history of mild, persistent asthma. On physical examination, a pruritic rash with areas of dry skin is seen on the antecubital fossa and cheeks. The mother reports that this rash seems to recur every winter. Which of the following conditions has a pathophysiology similar to that responsible for this patient's rash? I want all of you to start thinking about the important clues as I hand it off to Boris.
Thank you, Sean. So we're going to kind of walk you through what we think are the important clues in this vignette. So demographics, 5-year-old girl. So great, now we know we're working with a pediatric case. And then what is she coming in with? Itchy rash, but then also duration, 1 month. That helps give us some clues as to the chronicity of this rash. And we ask that a lot in dermatology, okay? We also know that she hasn't been around any sick people, hasn't traveled recently. And then importantly, the patient has a history of asthma. So that's going to be important, that past medical history, especially in pediatric patients who don't often have a lot of past medical history. That's important when they tell you that, okay? They give us some physical exam findings, which is perfect when we're talking about rashes. So we know it's itchy and there's dry skin. Specifically, what is the distribution? Well, the antecubital fossa and the cheeks, okay? And furthermore, we're given another clue that this rash seems to recur every winter, so recur every winter. So hopefully your brains are starting to think what this could be. So then we go into that lead-in. Which condition has a similar pathophysiology to that responsible for a patient's rash? So how many steps is this question? Well, let's work backwards. 1, we need to figure out what is this patient's rash? What's going on? That's step number 1. 2, what is the pathophysiology of that rash, of that condition? 3, which condition of the answer choices has a similar pathophysiology to that? So a nice 3-step question here. So let's go ahead and take a look at those answer choices. And once again, we are going to start our way at the bottom and work our way up to the top. Answer choice E, tuberculosis skin test response. D, Stevens-Johnson syndrome. C, shellfish allergy. B, Goodpasture syndrome. And A, Arthus reaction. So go ahead and select the answer choice that you think is the best answer here, and we will talk about it in just a few seconds.
Excellent. Thank you, Boris. So We'll give all of you a few seconds here to respond. If you are ever confused about about the answer choices, you don't know what the right answer is, remember to always take your best guess, because there is no penalty for guessing on test day, and certainly no penalty for guessing now. Keep in mind also that all of your responses today are completely anonymous, so they will not be shared with anybody. So just take your best guess. We'll wait until about 2/3 of you have responded, and then we'll go over the correct and incorrect answer choices. All right, looks like there's a clear favorite already. We'll give you a few more seconds. All right, and 60% of you selected shellfish allergy. So let's see if that's the correct answer. And indeed, it is the correct answer, and 60% of you got it right. So way to keep the momentum going. Great job, everybody. I'll hand it back over to Paris.
Thank you, Sean. Great job, guys. So hopefully you guys picked up on what this patient has. So this patient has atopic dermatitis, which is the technical name for what we commonly refer to as eczema, okay? It's a young child with a history of atopy, A-T-O-P-Y. We know she has a history of asthma, okay? The rash is itchy. The hallmark of atopic dermatitis is itchiness, okay? And then on top of that, it recurs in the winter. In the winter, your skin gets more dried out, so you're more likely to have atopic dermatitis. On top of that, it occurs in the antecubital fossa and the cheeks in this patient. So flexural areas are very common, especially as you start to get older. In more younger children, you can see it especially on the cheeks. So she kind of has a little bit of an overlap involving both the cheeks and the flexural areas. So on the next slide, Sean has actually gone ahead and pulled up the table from first aid that talks about hypersensitivity types. And as we see there, type 1 is called the anaphylactic and atopic type sensitivity. So it is a type 1 hypersensitivity. Other types of type 1 hypersensitivity reactions include anaphylaxis. So food, drug, bee sting allergies. That would be, of the answer choices that they gave to us, the one that would best fit with a type 1 would be a shellfish allergy, okay? So a shellfish allergy would also be considered an allergy to food, which could lead to anaphylaxis, and that, as you can see there, is also a type 1 hypersensitivity, okay? Type 2, as you can see there in that very first row, type 2 is antibody mediated, type 3 is immune complex mediated, and type 4 is delayed or cell mediated hypersensitivity. So now let's go back to our question and look at the other answer choices. Answer choice E and answer choice D, tuberculosis skin test and Stevens-Johnson syndromes, these are both examples of type 4 hypersensitivity reactions. Another classic one is poison ivy or contact dermatitis, but this is not contact dermatitis, this is atopic dermatitis, okay? So answer choice E and D would be more consistent with type 4. Answer choice B, good pastures, that would be more consistent with type 2 hypersensitivity, where you have an antibody-mediated pathogenesis, okay? And then lastly, an Arthus reaction, that's an example of a type 3 hypersensitivity reaction, where you have antigen and antibody complexes that deposit somewhere, okay? So in this question, the one that is most similar to that of atopic dermatitis, which is type 1, is shellfish allergy.
Excellent, great job, everybody. 60% of you got it right, and that wasn't an easy question, so well done. And we've talked about RX Coach a few times, and we talk about it every time we do one of these labs. And we've had so many success stories with RX Coach that we want to make sure that you know what we have to offer in the event that you're interested. You know, we have students that come to us all the time and say, oh, I read this on the internet, my friend did this, or my friend did that, and it worked for them. Well, that's great, and we're of course happy for your friends and your colleagues' success, and we wish you success as well. But keep in mind that every student is different. What worked for your colleague or your friend may necessarily work for you only because you think differently, We all learn differently. We all apply what we know differently, and we have different strengths and weaknesses. So one thing you can do if you're kind of stuck, you don't know what to start studying or how to study or how to make a plan or how to identify your strengths and weaknesses, and you want to study more efficiently, reach out to us at rx-coach.com. We'll start you off with an assessment. We are one of the only companies that actually created a tutoring assessment, as well as resources like first aid, RX 360, which includes our question bank, our express videos, our flashbacks, and of course, RX bricks, right? So you want to get tutoring from somebody who has experience in medical education. And we have a lot of experience teaching people and a lot of data points before we even started tutoring, which is why I think our data-driven approach has been so successful with our students. Then we'll work with you on a one-on-one basis to implement that study plan, but also work on your test-taking skills. There are a lot of USMLE courses out there, and they'll teach you the material, but none of them really work with you on a one-on-one basis to identify your strengths and weaknesses and then work on those test-taking skills. So if you're interested in maximizing your potential, reach out to us at rx-coach.com. You can work with one of our highly trained certified tutors like Boris or Alec. And we can talk about that at rx-coach.com. Click on the free consultation tab, and we'll talk about the program and how it can benefit you. If you're interested in some general study advice or a free study planner, we have that available at firstaidteam.com. So with that, let's go ahead and move on to our third question of the evening. Once again, the answer choices are covered up, and we will begin with the lead-in. Which of the following processes is most likely defective in this child's disorder? Which of the following processes is most likely defective in this child's disorder? So I'll give all of you a few moments here to think about how many steps this question will require. All right, let's read that vignette. A 2-month-old full-term boy is brought to the clinic by his parents for a well child visit. He is breastfeeding well and gaining weight adequately. He is producing the appropriate amount of wet diapers and bowel movements per day. He coos and smiles during the visit, but is unable to hold his head up. It is found upon physical examination that he has a large head with a prominent forehead, a long, narrow trunk, and short extremities, especially in the proximal segments. The growth chart shows significantly short stature for his age group. Which of the following processes is most likely defective in this child's disorder? And if this question looks familiar to you veterans for our question labs, it should be, because we've done it before. So I want you to start thinking about the important clues in this vignette as I hand it off to Boris.
Thank you, Sean. So once again, we will walk you through what we think are the important clues in this vignette in the lead-in, okay? So demographics. This is going to be a very pediatric case, a 2-month-old full-term boy, okay? So why are they giving us a 2-month-old question? Well, we know he's gaining weight adequately, so that's good. We know that he is cooing and smiling during the visit, and so when you see that, you should be thinking about milestones potentially. But then they say he's unable to hold his head up. Okay, unable to hold his head up. And then some physical exam findings. He has a large head, prominent forehead, long narrow trunk, and short extremities, especially the proximal segments. So a lot of important physical exam findings. Per growth chart, he is considered short stature. So now the lead-in, which process is likely defective in this child's disorder? So how many steps do we think this question is? Well, 1, I think we need to figure out what this child's disorder is, step number 1. And then 2, what process is defective in that disorder? So probably a 2-step question. So let's take a look at those answer choices and see what we are working with. Once again, we are going to start at the bottom and we're going to work our way to the top. Answer choice E, secretion of osteoid by osteoblasts without a hyaline cartilage model. D, production of hyaline cartilage models. C, mineralization of cartilaginous growth plates. B, excessive resorption of cartilage. And A, defective osteoclast resorption. So a lot of words there, but important to differentiate those answer choices. So we're going to go ahead and open up that poll. Go ahead and select the answer choice that you think is the best answer, and we will talk about it in just a few seconds.
Excellent. Thank you, Paris. I will go ahead and read these answer choices to you again, starting at the bottom. E, secretion of osteoid by osteoblasts without a hyaline cartilage model. D, production of hyaline cartilage models. C, mineralization of cartilaginous growth plates. B, excessive resorption of cartilage. And A, defective osteoclast resorption. So we'll give all of you a few more seconds here to respond. And then as always, we'll go over the correct and incorrect answer choices. I see some people mentioning the condition, but remember, that's not what this question is asking. All right, we'll give all of you a few more seconds here. And let's go ahead and take a look and see what you selected. And it looks like 40% of you selected C, mineralization of cartilaginous growth plates. And in second place was D, production of hyaline cartilage models. So let's see what the correct answer is. And the correct answer is D, production of hyaline cartilage models. And 24% of you got it right. So it was a challenging question, but if you got it right, great. Let's make sure you got it right for the right reasons. And if you didn't, don't worry about it. This is a learning process. Paris is going to explain it to you now, so you can knock this question out of the park on test day. Paris.
Great, thank you, Sean. Yeah, definitely a tough question. So this is a 2-month-old boy with, as we mentioned, a large head with a prominent forehead, short limbs, and short stature, okay? So automatically, hopefully you guys are thinking of a condition called achondroplasia, okay? And specifically, achondroplasia causes shortening of the limbs in the proximal segments, especially of those long limbs, okay? You get macrocephaly with frontal bossing, which is what explains his large head and large forehead. Interestingly though, this is kind of a process that talks about the long bones, okay? The long bones of the limbs form via endochondral ossification, okay? And on the next slide, Sean has actually gone ahead and pulled up a very important table that talks about bone formation, okay? So at the very bottom, we see here achondroplasia, okay? So it's a failure of longitudinal bone growth or endochondral ossification that leads to short limbs. So what is endochondral ossification? Now let's go back to the bone formation table, okay? So it's where you have a cartilage model of bone is first made by chondrocytes, and it then gets replaced with actual bone. So you start off with a cartilage model, okay? Now, when we look, and you can also see there that it's defective in achondroplasia. In membranous ossification, these are different bones. These are bones of the skull, bones of the face, and this is where you have woven bone formed directly without a cartilage model, okay? So the important difference is, do you have a cartilage model to begin with that you can then replace with bone, okay? And that's endochondral ossification. So let's take a look back at our question. Hopefully you can see now why in achondroplasia, the process that's defective, the best answer choice would be D, because that best describes endochondral ossification, where you have those hyaline cartilage models being produced that serve as essentially a template for those long bones to be formed, okay? And let's talk about the other answer choices and why those are incorrect. So answer choice E. This is actually specific and yet again intramembranous ossification, where you do have bone formation, but it's without a high cartilage model. So that is not consistent with endochondral ossification, and that would not be defective in achondroplasia. Answer choice C, mineralization of those cartilaginous growth plates. This is something where, if you were to have a defect in bone mineralization, you can see that in rickets in children or osteomalacia in adults. However, signs and symptoms of that would include those classic bow legs, having bead-like costochondral junctions, or a soft skull, which we refer to as craniotabes, none of which we have here. Answer choice B, excessive resorption of cartilage. So this is getting at a defect in osteoclasts, okay? And an example of excessive osteoclast activity would be Paget's disease. In Paget's disease, you can have hearing loss due to a thickened auditory foramen, and you can have an increase in hat size. So while we do have an increase in head size, we don't really have other signs and symptoms of Paget's disease, and on top of that, the physical exam fits better with achondroplasia. Lastly, answer choice A, defective osteoclast resorption. So if you were to have that, that could potentially cause osteopetrosis. Again, symptoms and signs with that would include pancytopenia, narrowed foramina, extramedullary hematopoiesis, things that are not being told to us in this question. So in this question, the best answer is achondroplasia, and really knowing and understanding the pathogenesis, not just for the disease, but also how normal bone is formed as well.
Excellent. Thank you, Paros. It was a challenging question, so hopefully we learned from it. Let's move on now to our last question of the evening and try to finish. Once again, the answer choices are covered up, and we will begin with the lead-in. Which of the following is the most likely diagnosis? Which of the following is the most likely diagnosis? I'll give all of you a few seconds here to let us know in the question box how many steps you think this question will require, and then we'll move on to the vignette. Coming in. All right, I see the responses coming in. Let's go ahead and read that vignette. A 28-year-old man comes to his primary care doctor because of a 2-day history of red discoloration of his right eye and joint pains that first began in his right elbow and right shoulder. 10 days ago, he was treated for a chlamydial urethritis with doxycycline. The urethral discharge initially got better, but now has returned. There is no history of arthritis. Which of the following is the most likely diagnosis? I want all of you to start thinking about the important clues in the vignette as I hand it off to Paris.
Thank you, Sean. So once again, we're going to show you what we think are the important clues in this question in the vignette and the lead-in. And the reason we're doing this is so that hopefully you can see how we're picking up on what clues are important, what things are not important, and that this repetition will help you, okay? So in this question, there's going to be a good amount, it seems like. So 28-year-old man, so demographics. We know there is a 2-day history of red discoloration of the right eye. So we also have duration there, which is good. We know that there's joint pains, began in the right elbow and right shoulder. They also gave us some nice history. 10 days ago, he had a chlamydial urethritis infection treated with doxycycline. That got better, now came back. No history of arthritis. So, which is the most likely diagnosis? Most likely diagnosis, great. How many steps is this question? Probably a one-step question. A lot of times the diagnosis questions are one step, just figuring out what's going on. Maybe there could be an added, a curveball in there. We'll take a look at the answer choices. So once again, we will start at the bottom and we will work our way at the bottom and work our way to the top. So answer choice E, systemic lupus erythematosus. D, septic arthritis. C, sacroiliitis, B, polymyositis, and A, gout. So go ahead and select the answer choice you think is the best answer, and we'll talk about it in just a few seconds.
All right, so we'll give all of you a few seconds here to respond and let us know what you believe the correct answer is. And then we'll go over the correct and incorrect answer choices. All right, I see the responses coming in. We'll give all of you a few more seconds here. Remember, there is no penalty for guessing, so if you're unsure, take your best guess. And if you're finding this helpful to walk through questions, have somebody explain things to you, and if you can, imagine how it would be if it was you one-on-one with the coach, and you like the idea of having someone guide you to make your study more efficient, help you pinpoint your strengths and weaknesses, work on those test-taking skills, reach out to us at rx-coach.com. All right, and it looks like 65% of you selected septic arthritis and 24% of you selected sacroiliitis. Let's see what the correct answer is. And the correct answer is C, sacroiliitis. So once again, a challenging question. 24% of you got it right. For those of you who didn't, don't worry. We're here to learn, and Boris is going to teach us now. Boris.
Great, thank you, Sean. Yes, definitely a tough question, guys. So let's take a look at this vignette again. So we have arthritis, we have conjunctivitis, and we have urethritis. So hopefully you guys are thinking about reactive arthritis, okay? It's a triad of conjunctivitis, urethritis, and arthritis. Used to be known as Reiter syndrome. It can be, the underlying etiology can be sexually transmitted infections, GI infections, and it's one of those conditions that we consider a seronegative spondyloarthropathy. And actually on the next slide, Sean has gone ahead and pulled up a table of those seronegative spondyloarthropathies, okay? Others include psoriatic arthritis, ankylosing spondylitis, and IBD. Now, if you look in that first row where it says seronegative spondyloarthritis, you can see there that it says there subtypes share variable occurrence of inflammatory back pain, okay? Sacroiliitis is a common finding in the seronegative spondyloarthritis, okay? And that's what they're getting at in this question. Sacroiliitis is a painful condition where one or both of the sacroiliac joints become inflamed, and this can be a symptom of reactive arthritis, okay? So let's go back and take a look at the other answer choices. As you can see there now, answer choice C, knowing that sacroiliitis is common with these seronegative diseases, that looks a lot better. But let's take a look at the other answer choices as well. Answer choice E, systemic lupus erythematosus. So you can have joint pain in that condition, but a lot of other signs and symptoms you would have that we're not seeing here. Rash, things like that. Answer choice D, septic arthritis. So classically, it's a patient with a very high leukocytosis in the synovial fluid, and there would also be systemic symptoms including fever, which we're not told about here in this question. Answer choice B, polymyositis. So polymyositis, like dermatomyositis, you can have symmetric muscle weakness, okay? But it would be, so this patient, if they are having pain or weakness in their proximal extremities, it would be symmetric and bilateral, not just on the right side, okay? And then lastly, gout. So gout also does have an asymmetric joint distribution when we're talking about pains, but it's more likely to involve your metatarsophalangeal joints, and then there's some risk factors such as red meat, alcohol, surgery, dehydration, and usually older men. So not a great fit for this question. So answer choice C would be the best fit here. Great job overall today with this tough topic, and hopefully we were able to teach you a few things today. Back to you, Sean.
Excellent. Thank you, Boris. Yes, great job today. We do have challenging questions as part of our question labs, but that's because you're going to have challenging questions as part of your exam. So if you're one of those students thinking, oh, I knew that, or I should have gotten that right, or maybe you're like, I don't know what happened there, reach out to us. Reach out to us at rx-coach.com. We're here to help. And students always tell us that once they start working with a coach, they start seeing progress more rapidly, and that they're actually saving time because somebody's actually giving them a focused and individualized study plan. So, it's an important exam. We don't want you to leave anything on the table. So please reach out to us if we can be of any assistance. One thing you can do if you're studying for your boards or you're in medical school studying is make sure that you're using the right resources. And I want to share one with you, which has been very successful for people, and we've had some great feedback on that. Of course, is our RX brick. So I pulled up a brick here on bacterial infections of the skin. As you can see, this brick is estimated to take about 13 minutes, and it starts off with learning objectives of what you can hope to learn and what we do want you to learn with each brick. You have a case connection, which will help bring this material to life. And then we have a learning module. And if you look at the text here, it's very conversational. It's not formal like a textbook. We have wonderful images. We even have images where you can take a quiz and cover up those labels to see what they are and see how well you know what these images are trying to teach you. As you continue in the learning module, you'll see more images and more text. You'll see tables as they're relevant. You'll also have flashcards that you can take a look at and use for review. Once you get to the end of the learning module, you'll have the case connection again to tie everything back together and a summary of the take-home points from this module. You also have practice questions, and once you get the answer right, you'll see an explanation of why that is the correct answer. And you can mark off the learning objectives based on how confident you are with them. And you can stay organized here because you can go deeper. You can go directly into our digital first aid, and First Aid 2021 is here to look at what this module was covering. You can study with flash facts and use spaced repetition. You can watch express videos if you want to learn more or bridge any knowledge gaps. And then, of course, you can quiz yourself and make sure you know how to apply the material you learned with our question bank QMax, okay? And Jeff will talk to you shortly about how you can actually access 150 bricks completely free of charge. So if you don't have bricks, I highly encourage you to do that.